everyone. I think we'll go ahead and get started. So I'll call this meeting of the El Paso County Public Health Board to order. And we'll start off with board member roll call. And Doris Ralston.
Here.
Commissioner Applegate.
Here.
Hunter Barnett, I believe, is online.
I am, Mr. President. I'm present.
Okay, thank you. And Dr. Chan, I think you're online.
Yes, I'm here.
All right, thank you. Commissioner Geithner.
Here.
And Mayor Havener, have we heard from her, Deanne?
We have not.
Okay. And then Dr. Vu. So we'll see. They may be en route. We'll see if they make it or not. But currently, Mayor Havener and Dr. Vu aren't present. So item number 2 is the approval of the agenda. I'll need a motion and a second for that. Is there a motion to approve the agenda?
So moved.
Okay, so Commissioner Geithner makes the motion.
Second.
Commissioner Applegate seconds it. All those in favor, please say aye.
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 Any opposed?
Aye.
Okay, and so that passes unanimously. And item number 3 is Board of Health comments. So we'll start off online, and we'll start off with Dr. Chan. Any comments today, Dr. Chan?
The only comment I have is I should have made this apparent before the meeting. It's related to the minutes. There was a question in the minutes that a citizen asked about the about updating septic systems, especially when it's passed on to someone in the family.
And Dr. Chan,
yes.
our next item is will be approval of the minutes. So if you don't mind, we'll just hold that until we get to that one, and then we'll make that correction at that point.
Thank you so
Sound
much.
good? Okay, yeah, thank you. And Hunter, any comments from you today?
No comments other than apologies for not being there in person. I'm fighting a bit of a cold and wanted to keep it to myself. And I'll be on video here shortly.
Okay, well, we hope you get better soon. And if there's a way to have the volume turned up, we can hear you guys, but we just barely hear you. So we'll try to get the volume turned up on our end. And with that, we'll now go to Commissioner Applegate. Any comments, Corey?
No comments at this time.
And to Commissioner Geithner.
Thank you. I do just have a brief comment. Folks may have seen in the national news and also around various states in the nation right now, there's a lot of conversation around SNAP benefits, food stamps, from using the colloquial term there, and what those should be utilized on. And I spoke to Deanne a little bit about this yesterday. Actually, it's something that I think that we should consider when we're talking about the chronic diseases that we've been talking about here. There is again, a federal kind of motion towards changing SNAP benefits so that they cannot be used on soda and junk food. Makes sense to me from a nutritional perspective that taxpayer dollars should go to fund healthy food for folks. And so I know that that is outside of the purview of public health specifically. That's obviously something that falls underneath the county. But I think that it makes sense for this board to possibly weigh in on that conversation. So I know that we are doing some investigation of what that would look like from the state level, what that would take. I know that in the past, the federal government has not been willing to issue waivers. They're now saying that they are for states. So just something for us to take up and consider whether that is something that we would want to add our voice to as we talk about how important it is for folks to get nutritious food. And just wanted to bring that to the attention of the board.
Okay, and thank you, Commissioner Geithner. And I see that Dr. Vu just walked in, so we'll be over to you for comments in just a moment, Dr. Vu. But Vice President Ralston.
No comment today.
Okay, and then I'll also pass on comments this morning. But Dr. Vu, you just walked in, and now we'll ask you for any comments you have for this month.
No comments, thank you.
No comments also. Okay. Any alibis from anyone? If not, we'll move on to the approval of the minutes. So hopefully everyone's had a chance to review the minutes. Are there any corrections to the minutes, and I believe Dr. Chan had noticed something in the minutes.
Yes, that's right. The question that the citizen had asked about the septic system upgrades when a property changes hands, in the minutes, it's saying that Kat McGarvey was going to respond to the citizen, but I believe her question was asked and answered during our last session, in which Kat McGarvey indicated that that these upgrades were not required if the property was being handed down within the family.
And I don't recall the specifics of that, but who is it that corrects the minutes for us? Or is Kat here? And Kat, do you feel like you answered the lady's question?
I did.
Okay.
I do just want to clarify what Dr. Chan had just said. It's not that the upgrades are not necessary. We just don't require the property sale process for in-family transfers. So, which by default then means that those upgrades would not be necessary because there would not be a property sale to necessitate that.
Okay,
But we
and
did answer that in the meeting.
you don't plan to contact her further, is that right?
We have sent clarification previously about that with her as well.
Okay.
I am also meeting with Green Mountain Falls community as of on April 1st.
Okay, so then, Deanne, can we just have those corrected? And
Yes, we would be happy to correct those minutes.
okay. Should we vote on those now or wait for them to be corrected?
I would suggest that someone could make a motion to approve the minutes with that amendment.
Yeah, that's a good
Ask our attorney if
suggestion.
that's the correct.
Yeah,
I think that would be an appropriate approach.
very good. Any other comments or corrections to the minutes? Nothing from you, Corey? Okay. All right, then, all those in favor of approving the minutes as corrected, please say aye. Do-
Did you,
I
did-
don't think
Do
there
you
was a
want,
I
do
was
you
gonna
want to
say, did
make
we
a
get a
motion?
motion?
Okay, go ahead. Oh, that's a good point.
I will happily make the motion to approve the minutes with the corrections discussed.
Okay, so we have a motion from Commissioner Geithner, and a second?
I'll second.
Okay, thank you, Commissioner Applegate. All those in favor, please say aye.
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 Okay, any opposed? Okay, then
Abstain.
are you,
I wasn't here.
oh, okay. And then, so Dr. Vu abstained from that vote. So the minutes are approved. The next item on our agenda is public comment for items not on the agenda. So do we have anyone online for public comment? Who is it that has such knowledge?
There's no one I'm aware of for public comment this morning.
Okay. Is there anyone in the room for public comment? Well, that made it awfully easy. So we'll move on to item number 6, which is finance and budget. And I believe Taylor Hartshorn, the budget analyst, will present that for us.
Good morning. Apologize. My name's Taylor Hartshorn. I'm a budget analyst with Public Health. I've been with them for about 2 years, for those of you who have not met me or don't know me. Am I on here? Is this on? Oh, thank you. Okay, so today we're going to look at end of year 2024's preliminary final numbers. These do have the ability to move slightly as the end of the fiscal year is finished out, but starting at the top, El Paso County revenue came in right where we expected. The county funding was right where we expected. State funding as well came in actually a little bit above where we expected due to some changes throughout the year and an increase in state funding that we received halfway through 2024. Program-specific grants, due to a number of 2 separate timing issues, what we had planned to receive in revenue from those program-specific grants across Fund 95 was less than we actually received. However, the flip side of that is the vast majority of those program-specific grants are reimbursable. And so we see the savings of not receiving that revenue in the personnel and operating lines further down the report. So we see about a $1.4 million savings in personnel and $365,000 in savings in operating. A large portion of that is due to us not expending those grant funds and then subsequently not having the expenditures to reimburse for. Licenses, fees, and permits, those came in a little bit low as we've sort of talked about throughout the year. There were a couple of areas in licenses and fees where the estimate was a little bit high as far as what we thought we were going to bring in as we budgeted in 2024. That was due to a number of reasons, market changing, interest rates, changing throughout the year of 2024. So we did have some of that. However, it was lessened in comparison to where we thought we might be in the middle of 2024. Medicaid fees and insurance did come in higher than expected in 2024 by about $70,000. Interest income came in right where we had expected, given the changing interest rate throughout the year. We're happy to see that. And then donations came in a little bit low, and those are pretty, they fluctuate year over year. They're harder to pin down. Personnel, as I mentioned, was about $1.4 million of savings there, vastly due to the program-specific grants and some personnel savings and intentional sort of work throughout the year. Operating, again, mostly due to that saving and program-specific grants. All in all, we had planned to spend about $572,390 of fund balance in 2024. When all was said and done, we spent $745,826. So we came in a little bit, about $173,000 over the anticipated use of fund balance. Again, just to reiterate, we are still far under the authoritative spending that was approved by the board in October, and then including any changes and revises throughout the year. So that's where we sit for 2024. Before you go to 25, 25. Any questions from board members? And I'm looking online. Any questions online? It looks like Dr. V.
Sorry.
Let's let Dr. Chan go. Go ahead, Dr. Chan.
I was just curious what our current fund balance is.
Given that these are not fully finished, I can't give you an exact number at this time. We can circle back with an exact number when I have the final 2024 numbers and they've stopped moving. However, I can say it is going to be about $173,000 less than we had anticipated to start 2025 with when the 2025 budget was approved by the board.
Do you have a general ballpark figure to within, say, $100,000?
I unfortunately don't have that number in front of me, and
Okay.
I don't want to misquote.
Okay. Is it, when you're finished with your presentation, and we'll have the director's report, do you think you could get that for us?
Yeah,
Okay.
absolutely. I
So-
can get you a ballpark number,
Okay.
yes.
We'll have a ballpark before we adjourn today, Dr. Chan. Any other questions, Dr. Chan?
No other questions, thank you.
Okay, thank you. And anything from Hunter online? Looks like not. And Dr. Vu?
Thank you. I have two questions. For 2024, the lower reimbursable revenue from program-specific grants, is that because we don't have enough staff? Is it because we're short-staffed, or is it because there's not enough work to be done?
So just in general, there was a couple of things that drove that number. There was a couple of these grants are multi-year grants. So we had anticipated to spend a little bit more money in 2023 than we did. And so, I'm sorry, the opposite, that we anticipated to spend more money in 2024 than we did. That was due to some of that maybe shifting into other multi-year grants like ARPA or CDC grants. So it's a multi faceted. We spent less than we anticipated, so we brought that back in due to timing of when we're expending these multi-year grants. And the budgeting process and how we budget for these grants, there was more money spent at the end of 2023 than anticipated, which meant there was a little bit less on some other grants to spend in 2024.
Okay. Thank you.
I can clarify if there's something specific.
No, thank you. Thank you.
Apologies.
Maybe next month I'll understand better.
Okay.
The increase in Medicaid billing revenue, do you think that was because of improvement in our billing process?
That's not something I could speak to programmatically at this time. I'd have to defer to Deanne or to...
Yes, and if I could speak to that briefly, Dr. Vu, we have been working diligently with our medical billing specialists. We have 2 part-time medical billing specialists to review our opportunities to seek Medicaid reimbursement for our programs that have eligible services, and they have been working to make sure we are maximizing those efforts, including working within our electronic health system to be able to follow those payments and make sure we're following up on those. And I do believe there's been a continuous quality improvement process with medical billing from our clinical services that has helped us realize that.
Thank you, Deanne. Can I ask again, do we bill Medicare?
We have very limited ability to bill Medicare, and that relates to our immunizations program. Because of one of the systems that we are involved in, we can do some limited Medicare reimbursement through the immunizations program, and that is something that our clinical services team has been working on. And really, I believe last year was the first year we were able to take advantage of that. So we continue to examine that, but it is quite limited at this point.
Okay. Thank you.
Okay, thank you, Dr. Vu. Any questions? Okay, I think that covers all the questions on 24, and then we'll go to 25.
Okay. So 2025, these numbers are as of February 28th through the end of February. El Paso County and state funding are right as we anticipated where they are based on those contracts currently. And program-specific grants, we're actually seeing we're burning a little hot on those. Again, it's timing. Most of those are fully reimbursable. And at this time, I don't have any concerns or anything moving forward as of now on those. Licensing fees and permits, we're showing some positive growth in those areas in certain fees when we look at year over year, February through the end of February or middle of Q1 compared to where we were last year. And again, we did adjust that budget number in 2025 to be more reflective of where we anticipate that revenue coming in. So we're continuing to monitor that number, but just anecdotally, there were part of the increase that we're seeing year over year in licenses, fees, and permits are due to some of those fee increases that were approved by the board. Some of those were phased in 2024 and 2025, and we are starting to see that revenue come in higher than it has in 2020, than it did in 2024 due to that. So again, that's something we're going to continue to watch over the year as license fees and permits are the big sort of driver that are not contracted. So Medicaid fees and insurance, we again, just like last year, we're seeing that billing come in high. Hopefully that we see that continue with that revenue coming in. And then interest income, we are below where we'd anticipated to be at this time in 2025. Contributions and donations, about right on target. Again, that's a minimal, that moves throughout the year, so it's hard to pin down. Personnel, we are a little bit underspent, as expected, as we move through the year. Hopefully continue to see those savings, and we, part of that is due to grant timing and continued direction. Operating, we are looking at a little bit of overspending and operating. That is mostly due to timing, some accounting things that happen at the beginning of the year that level out throughout the year. And then there's been no expenditure of capital in 2025 so far. So at the end of February 2025, we're in a good spot as far as the budget looks and where we expect it to be at this given budget as of today.
Okay, thank you, Taylor. And questions from board members? Yes, Vice President Ralston.
Hunter, can you clarify just for me, this includes January and February. This is not just for the month of February,
Yes,
correct?
this is year to date as of
Okay.
February 28th.
Thank you.
Yes.
Dr. Vu.
Thank you. So I'm assuming salary for 2025 has not decreased compared to salary in 2024 in general. Personnel expenditure for 2024 is 21,000. First 2 months of 2025 is 3,000. So that's a
Yeah.
slight suggestion of operational difficulties.
I'm sorry, are you referring
Are
to?
are we much more understaffed compared to 2024?
Our total staffing level has changed since 2024, but as far as, again, programmatically and operationally, it's not something I can speak to as far as where we're at there.
And if I can speak to that a bit, we are monitoring our FTEs as we move throughout the 2025 budget, knowing that we anticipate some changes in funding availability coming to the agency. Our approach for the last year plus has been to evaluate vacancies as they become open to assess if they're if the vacancy needs to be refilled, and if there are structural changes that might allow us to prioritize work differently. So we are being very cautious in filling our vacancies in anticipation of potential changes in funding and reductions in funding coming to public health, and that is something that we've been discussing with our team over the last year as we move further out into the post-pandemic period and a need to have sustainable staffing. So we continue to examine FTEs. It is typical for us to have some vacancies at any point in time during the year, and as vacancies become available, we continue to assess whether or not we refill those.
Thank you, Deanne. Can you, just in general, our FTEs now, the end of April, the end of February 2025, less than say 3 or 4 months ago?
Yes.
Okay.
Yes.
Thank you.
Any questions online?
Yes, it looks like Dr. Chan and I have our hands up. I think I got in there first. So I'll go first. So I actually did want to go back to the fund balance question from Dr. Chan. I thought I recalled covering this in my orientation, and sure enough, we did. And we don't have to get into it now, but one of the things that was highlighted during that discussion back in December, and I think we as a board should keep top of mind, is that fund balance and what to do with it, for 2 reasons. One, I'm seeing a number that's about 8 million. I think that's the 2023 number. And I think that more importantly, it's about 30% of revenue. And there was a Board of Health fund balance policy adopted in August of 2016, which says that that fund balance can only be 18 to 21% of revenues. So 30 is higher than 21 considerably. So maybe when we continue this discussion on what the actual fund balance number is, what we expect it to be for 2025, I think we should have a discussion on why is it so high and continues to be so, and if we do need to do something about it, bringing it back down to 18 to 21% of revenue, what does that look like do we need to have a conversation on it anytime soon?
Okay, thank you for that, Hunter. I think Dr. Vu has a thought on that.
Thank you, Hunter. Thank you. This has been on our minds for the past couple of years. We do have a very healthy fund balance. I mean, our cash flow from time to time has been difficult, and our cash flow now is not too bad, but our fund balance, our days of cash in hand is very, very healthy. So that's where my mind has been, is into operations. Do we use the fund balance to help operations, right? If we're short-staffed, because if we have too much work and we don't have enough staff to take care of do all the work, then it will be very appropriate to use the fund balance to supplement that. We talked about that 2 years ago when we were anticipating 2024 would be difficult. So that's where my question is, if we're trying to appropriately staffed without sacrifice, if we don't have enough work to do, then of course it's okay to cut back on personnel expenditure. But if we have enough work to do and we don't have enough staff, then it's appropriate way to supplement that with fund balance. And when we talked about this, we anticipated this at the end of 2023.
Mm-hmm. Okay, thank you, Dr. Vu. And we will get that current amount from Taylor a little later in this meeting. Any other questions regarding the first 2 months of 25? If your hand is up, Dr. Chan, I just can't see it. The television's small, so I just can't see if your hand's up. Go ahead.
Yes, I actually wanted a little more clarification on the variance in the operating expenditures. I wanted to understand if there are program-specific grants where there are differences in timing of execution of the grants versus collection of grant fees, how personnel expenditures can be under, but operating expenditures are over.
Thank you, Dr. Chen. So there's a couple of things there. When we talk about over or burning hot or over or underspending on program-specific grants, we're talking in comparison of where we expect that to be throughout the year. To get to your first question, there are very few grants. There are a couple that we have that we receive on a quarterly or monthly basis. But the vast majority of program-specific grants are reimbursable, and we collect that money or very close to it at the same time that we expend it. We invoice for it and we receive that money back. So when we talk about the program-specific grants being over or under, and then the personnel and operating not lining up, there's a lot of personnel that is not billed fully to program-specific grants. So the personnel number could be under while the operating is over, and the operating personnel is not split evenly across grants. So if with program specifics on these, I'd have to circle back. I would have to be able to pull that specific detail to have, an answer to anything specifically. But in general, it's not exactly a one-for-one on paper, because they're not, most employees and most grants are not exactly that one-for-one trade-off.
Are you saying that with the program-specific grants, some of the operating expenditures occur during quarter one, but are not reimbursed until, say, quarter 2 or 3?
In general, no. The vast majority of our program-specific grants, when they're reimbursable grants, if the expenditure takes place in February, they're invoiced in February and the money is received in February. So there are, in almost all cases, the money is received in the same reporting period that it is spent from an accounting standpoint.
Okay, and so I just don't understand how it's a timing issue if the case is that the reimbursable operating expenditures are spent and reimbursed within the same time period. how does the variance, um, how is the timing affecting the variance?
And Taylor, may I speak to that a bit? I think one of the items that may impact this as well is for our grants and for the purposes of budget, we estimate fairly consistent spending throughout the year. However, one-time purchases may impact timing as it relates to an assumption in the budget of fairly consistent and even spending. But if we have to make a purchase, say, for medical supplies or pharmaceutical supplies, that could be a variation of the spending that draws more operational funds at a particular point in time to support a purchase, to support a specific effort that evens out throughout the course of the year. We'd be happy to look more specifically into where some of those are originating from to provide more insight into that. But in general, also when we have significant purchases, sometimes the timing of those purchases, and Taylor, if you see this differently, please speak up, but timing of those purchases can also draw increased operating expenditures in a particular month that will even out over the course of the year.
Okay. Dr. Chan, do you have further questions? Dr. Vu is, he has his hand up here in the room.
I'm going to let Dr. Vu chime in because I'm still processing that information.
And I'll just say I see this over at utilities where spending isn't even every 12 months, but it's kind of estimated to go that way. And so some months will be, have spending over, and then the next month it's under because the stuff was purchased the previous month. So I think a trend would be very important. If each month this continues to get farther apart, we got a problem. If it comes back together next month, we can get the details on why, but that's what I would expect. And Dr. Vu, go ahead.
Dr. Chan, I think you're talking about the operating expense for the first 2 months of 2025 of $600,000. I think the first 2 months of $600,000 in 2025 is still less than what it would have been in 2024 of $6 million for the year. So in that scenario, in my mind, the variance in 2025, the first 2 months of $71,000 is still within a margin of error.
Thank you, Dr. Vu. Dr. Chan, do you have any further questions?
I don't believe so. Thank you.
Okay. And then Hunter, we still are going to get that estimate for our fund balance. We'll get that during the director's report.
And
I can't remember if you'd completed your presentation or not.
yes, so
Taylor,
I have. So just one last point to clarify for Dr. Chan and for the board.
Yeah.
When we're looking at those variances month over month, like we stated, that we are estimating that based on trends, a conglomeration of trends and month over month spending year over year. But when we look at this specific report, if we look at program specific grants, we've brought in about $100,000 more than we'd expected to have brought in as of February 2025. And then in operating, we've spent about $72,000 more than we would have expected. So we have brought in more revenue than expected and spent a little bit more operating expected. So those numbers do align when we're looking at that.
The grants.
As far as operating in the grants.
Mm-hmm. Okay.
Perfect. And I will get a fund balance number for you.
Okay. Any other questions before we let Taylor wrap it up? And Commissioner Geithner.
Thank you. I really appreciate the discussion around this. So I have a couple of questions, but also a couple of comments. One is, I appreciate Hunter's question around the fund balance. I know we're going to get a dollar amount on that, but can we also get the specific percentage of budget as well, because that was relevant to the question that he asked. I don't think that it is quite at 30% now from other conversations that I've had around this, so I think it is lower. And then I wanted to remind everyone that, of course, we're spending into that fund balance, so it is going to be we're going to see a
down.
decrease in that from this budget year. So we are going to see it actually come down below that number. And then a couple of things. So the term burning hot was used on some of those grants. And I wanted to acknowledge and kind of connect the dots that I know I am seeing, which is we're burning a little hot on some of those grants, which may or may not be an issue at this point, but as we get down the road, we've talked about the grants that are not coming back. Deanne's done a great job of explaining that we're down on the downslope considerably of a lot of those COVID era dollars that are not going to be continued, and that the reason that, and thankfully, and I want to say thank you for the great work that you're doing on this, to evaluate each one of those FTEs, because the original FTE count by our general fund, kind of sustainable funding, is not going to continue to support that same number of FTEs. And I think recognition of that and continuing to work towards understanding that that is going to change is really admirable and is very smart for the long-term future, which we're not going to see in this 2025 snapshot, but is an ongoing concern. But I also wanted to point out specifically that I think we're talking about two things, which is ongoing FTE, ongoing kind of costs, and then we're talking about a fund balance and dipping into that, and we can certainly use that temporarily for ongoing expenses, but we obviously don't want to get into the habit of spending into your fund balance for ongoing expenses. We want to use those for more one-time, even when they do need to be expended down to meet that, that balance, because obviously it's much more difficult and not pleasant a lot of the time to eliminate FTEs because you're dipping into that fund balance. I think, was it $1 million that we were dipping into the fund balance for 25?
Our budgeted 2025 that was approved by the board was about $970,000, a little bit more of that.
So even though, $8 million seems like a lot, just by the end of the year, dipping into that by $1 million is obviously significant. And if we were to do that for another year, we can clearly see how quickly it would deplete that. And so I think that forecast on what that percentage is going to look like, I don't think that we're going to end up dipping into it for those ongoing expenses because of the work that Deanne has mentioned that they're doing on, to use the term, kind of right-sizing the organization from an FTE perspective. So just wanted to say thanks for the great work and all the great questions on this. Looking forward to hearing more about what those exact numbers are in the fund balance. Thank you.
Okay, thank you.
Dave,
And Dr. Vu.
I'm sorry. So Hunter, I remember the two numbers, 30% and 18%. And if someone can please clarify, my memory is that the recommendation is that we should have at least X percent, probably 18% in the fund balance, and not that we should not have more than 18% of fund balance. But if someone can clarify that for me.
Yes, I can clarify. So the recommended fund balance that was adopted in 2016 was the minimum fund balance policy is 18 to 21% of revenue, of budgeted revenue. So I will get those numbers for you, and I'll get you a little bit more clarification on what that means when I get the actual numbers. So,
thank you. So
yeah,
at this time, then my understanding still is that the recommendation is the floor should be at least 18 to 21%, and not that we should we should not have a fund balance more than 21%. But we'll clarify that.
Well, that's correct from my memory, Dr. Vu, and because I was here then.
Thank
and
you.
Also the idea was that we would not dip into the fund balance for operations unless it was really necessary, that it would be for one-time expenses that were unusual, like maybe the purchase of a vehicle or whatever it happened to be.
Right, thank you.
And I think the important thing that Dr. Vu's pointing out, and it just goes to the question that Hunter raised, is that 18 to 21% a minimum? And we don't have a policy that it shouldn't go above that, and I think that's right. Or do we have a policy that we're supposed to stay down there? I don't think that's correct. I think in years when we're having higher income, we can increase the fund balance. For years when we're transitioning away from funding and things like that. So, man, you got some homework there, Taylor. And we have one more comment from Commissioner Geithner.
Yeah, I just want to say, my understanding, because I've seen the policy, is that, yeah, that's a floor, there's not a ceiling. However, I'm going to state, I think it is good practice, however, to not have huge amounts of taxpayer dollars sitting in a fund. I think taxpayers expect that if those dollars are needed, that we have a reasonable cushion to make sure that we are sustainable in the future. But at the same point, we expect those dollars to be expended and utilized in a way to benefit the community. So while there may not be a cap, I think it's wise for us to consider trying to keep that in a smart place, which may be a bit higher at times when we anticipate those needs coming up. And I'm guessing that there are probably more one-time needs or capital needs that are on the horizon or in the mind of our director, and that maybe could be shared in the future of if we do end up. My concern is that we end up, if we were to end up kind of ramping down on some of this grant funding and dipping more, and then we could actually go below that floor very, very quickly if we're not careful, which is why I'm very, as I said, I'm very, very pleased to hear how much consideration is going into that. But I do think that that is something that it's the margin can be kind of razor thin when we're talking about, dipping at $1 million at a year, right? It only takes a couple years to get draw down on that pretty quickly. So I don't think that's going to happen from what I'm hearing from Deanne. But I do think if there is a kind of a forecast, if you will, into the next couple of years and what some of those capital or one-time needs might be if we think that we're going to get there. But my guess is that fund balance is not going to continue to grow at the same type of rate. So there may not be as much planning there. In that case, it may be more funds that are more stable now that we're getting into this kind of post-COVID, less federal dollars, less grant dollars that are flowing in.
Okay, thank you, Commissioner Geithner. And I can't see hands online, so if someone has something online, please just speak up. But other than that,
I think we really just need a number, because we don't know what the number is, and we don't know what our fund balance percentage is. I would expect that it's probably less than 8 million, because didn't we go into it by about 700,000 last year, and then we're budgeted to go into it for almost $1 million this year?
Well, Dr. Chan, if we let Taylor get away from that microphone, he's going to get the number for us.
Okay.
So I think we should release him to go do what he can do. And so we will have that number here during the director's report. So, Hunter, I know you want to hear that number. You good?
I'm good.
Okay. And then in the room, we're good? Okay, Taylor, thank you for that presentation. And I know you'll come back. You can pass it to Deanne, or you can present it yourself.
Okay, I appreciate it. Thank you.
Okay, thank you. And I want to thank all the board members for that, for showing some sincere interest and concern with doing this right. And with that, I will now hand it off to Deanne for the director's report.
Thank you so much. And for the director's report, I would just like to start by with gratitude. I thank the board for the opportunity to serve in the interim director role. Having spent 10 years with the El Paso County Public Health team, I am always impressed by the dedication and commitment to public service that our team brings, and I am very honored to have the opportunity to serve in the interim role. And related to the interim role, one of the first things that we have prioritized as a team in public health is to look at how we support our agency during this interim structure. Our team, in our first responder role, we do quite a bit of training around incident command system and responding to changing events. So kind of following in that theme, we have made some changes to our interim structure to help support continuity of business operations. For those of you who are in person today, at your seat, you have a copy of our interim organization structure. And for those of you who are remote, our board liaison will send that after this meeting. But we just wanted to keep you up to date about changes we are are making to support the interim structure. And with that, there were a couple changes that I wanted to draw your attention to as we support the agency in this interim period. I'm very pleased that one of our division directors, Michelle Byerly, who has been with the agency and a member of our executive team since 2020, has stepped up to assume the role of acting deputy director, and that will help us provide continuity to the agency and support routine operations. And also in an acting role, Janelle McNair, who has served as our emergency response division manager, has stepped up for a acting division director role, and we're leaning into her expertise to be able to support areas of disease control and response readiness. And she will be overseeing teams in communicable disease, emergency management, as well as our public health laboratory. And then not in an acting role, but consistent with previous conversations we have had about budget management within the agency, we have also filled our departmental budget manager position. Lauren Mearmont has joined our team. She's been with us for about a month now, so she is still onboarding and cross-training with Taylor and the county budget team. I anticipate we will remain very closely connected to the county budget team as we move forward, but I am grateful to have the opportunity to have a budget manager in-house, and that will create the opportunity for more connection with our programs and our teams and strengthen some of that understanding as it relates to budget management on a daily basis. And I just wanted to pause there, and Janelle is not with us today, but Michelle and Lauren are here, and I just wanted to ask if they could step up and introduce themselves to the board, please.
Good morning, members of the board. Thank you, Deanne. I'm incredibly honored to serve in this acting capacity, and I feel very grateful and fortunate for Deanne's leadership. I've been with the agency for just under 8 years in a variety of different roles, very passionate about health and wellness and local government and the opportunities that it's provided me to serve our communities and residents. So thank you for that opportunity, and looking forward to the things that we'll be able to do together into the future to support our shared goals.
Yeah, thank you, Michelle.
Hi, good morning. I'm Lauren Mearmont. I'm a CPA, so I bring a little bit of accounting background to the role. I've always worked in government accounting, most recently at Jefferson County, manager of accounting operations there. I've never worked for public health, but I worked with public health, so I'm excited for the opportunity to be here. And I have a lot of experience with grant financial management and just really understand the operations in government finance. So I'm sure you'll be seeing me more shortly in the future, but just wanted to say hello. Thanks.
Okay, thank you, Lauren. And you can tell by all those questions that we're not really interested in budget stuff. So. Thank you.
Thank you. And then we also wanted to be responsive to some of the questions that have come up regarding chronic disease and what public health does in this arena. So for the director's report today, we do have some information about chronic disease that we would like to share and some of the public health programming that we have in place that address chronic disease within the agency. As we move forward and funding streams in public health change, I anticipate that there'll be more opportunities for us to work in this arena. And I'm grateful for the work that is existing that we can build from, as well as the diligence of our development officer to prepare us to be able to seek those opportunities as they arise and as some of the public health funding streams may change. But with that, I would like to ask Daisha Hudson, who serves as our Community Health Promotion Division Director, to lead us through that conversation.
Yes. Good morning. My name is Daisha Hudson, Community Health Promotion Division Director here at El Paso County Public Health, and I'm here today to talk to you about chronic disease prevention. So as we know, chronic diseases are generally long-term conditions that require ongoing medical treatment and can negatively impact one's quality of life. And we know that most chronic conditions are caused by risk factors such as smoking, poor nutrition, physical inactivity, and excessive alcohol use. And unfortunately, chronic diseases are among the leading causes of illness, disability, and death in El Paso County. The top 2 causes of death in El Paso County are cancer and heart disease. Here at El Paso County Public Health, we aim to prevent chronic disease by implementing programs that promote healthy behaviors, advance policies for healthier environments, and working with community partners to address risk factors. So we're really trying to work to prevent chronic disease before it occurs, or help those that have already have a chronic disease manage that through healthy behavior change. The Community Health Promotion Division is primarily made up of programs and initiatives that strive to prevent chronic disease. We also know that chronic disease is a comprehensive problem and it takes comprehensive solutions. And so we're really invested in our strategic partnerships out in the community to help tackle the chronic disease burden here in El Paso County. Today, we would like to highlight 2 of our initiatives, programs, RISE Southeast Colorado Springs, and the Tobacco Education and Prevention Partnership. But before I hand it over to our next speaker, I just wanted to give a high-level overview of how RISE Southeast Colorado Springs started. In 2016, El Paso County Public Health received an El Pomar Foundation Possibilities Grant, and that really provided the foundation and a 7-year commitment that allowed this initiative to develop and become sustainable over time. And just so you know, RISE stands for Resilient, Inspired, Strong, and Engaged. And that acronym was developed by the community in Southeast Colorado Springs. During that 7-year commitment, we were able to hire a community outreach coordinator that engaged with the community through a coalition, resident leaders, and youth from Southeast Colorado Springs. I'm excited to introduce to you Joyce Salazar. She was a resident leader. She was also our community outreach coordinator, and she's now the executive director for RISE Southeast Elevate. So we're super excited. We feel like this is such a success for a public health initiative to transition to the community and our partners, and for the community to have such buy-in to carry the work forward. So I'd like to welcome Joyce Salazar.
Good morning, everyone. Again, my name is Joyce Salazar. This morning when I walked into the building, it was just like coming home. So I was the community outreach coordinator for 7.5 years here at Public Health. And when I started, I knew nothing about public health. However, as a resident of Southeast Colorado Springs for over 40 years, I started to understand how important public health is to the community, and the education that it brought to me, it now carries on through our organization, which I'm so glad to say we've just completed our first year as a nonprofit and continue the work that was started here. I will just say the 2018-2023 Community Health Improvement Plan was a roadmap that I used because, like I said, I didn't know about public health. So I used the information that was available through public health to help guide our action plan and to promote public health during my time here. So I've never used this clicker before. I have a really nice presentation for you this morning. But what I'd like to say is, yes, chronic health disease, this one, yep, is prevalent in our community. And through public health education for myself, and also connecting with the community, the resident leaders, and our youth, we have taken on the challenge to make a change in the community. So our vision is a vibrant, connected community that offers opportunities for all to thrive. Our purpose is Southeast Colorado Springs will be a destination for culture and diversity in our city. Our mission is enhancing Southeast Colorado Springs from within through resident-led change. So in 2017 is the time that I'm most familiar with. There were previous things happening that led up to the Southeast Possibilities grant from Alpamar. But I joined as a resident leader, as Daisha said. I was one of 7 community members that came together with partner organizations to develop a planning during our time of planning for an action plan that we proposed to Alpamar. Because of that plan, Alpamar granted us the 7-year $350,000 grant, $50,000 over 7 years. And that was used partially to fund my position. Also funding my position was a grant through the Colorado Health Foundation for WIC outreach. So there were several pots of money that funded the position of the community outreach coordinator. And during that time, my job was to speak with community, to meet community and share the things of public health, and also gain information from them. And what we were finding out was in that community, 80910, 80916, people really needed access to healthy food, access to transportation, access to resources. And so listening to the voice of the community and their needs, they were saying the same things that people in public health were saying, but they were just saying it differently. And so I appreciate the conversation this morning about SNAP benefits, because access to nutritional food is really important to the community. And so I'd love to have a conversation with you about that. I'll continue though. I get off track sometimes. But so as you can see through the slide, we've continued to work towards the same things and the same goals. One of the things that we're really proud about is the Panorama Park project. So community was saying that they wanted a place to gather. They wanted a place where they could celebrate, a safe place where they could go and walk through the community or just sit down and read a book, a place where they could have farmers markets, a place where they could just feel a part of something. And so as I look back on our action plan, we touched on all of the things for that action plan. And we talked about increasing capital, right? Increasing community capital, increasing built capital, financial capital, cultural capital, and human capital. And so it touched on all of that. And as I look at it today, it also touches on food access. We've had farmers markets there. It touches on mental health because there's a safe place where people can go and they can read a book. They can walk and feel safe. They can allow their kids to play. I take my grandkids there all the time. They're playing basketball and I'm walking around the park, but I can see them and I feel safe because I know that this place is safe, and that is really important for the community. So I get off tangent, and I get on tangent, and then I forgot my notes this morning, so I am just going to speak from the heart this morning. The Panorama Park project is for community built, not built necessarily like with shovels, but inspired, created by the community for the community. And so these are just some photos of what community engagement looks like from the ground up. The mural project that you'll see right there, there's another art project on the other side. A total of 7,200 2-inch tiles went into each went into both murals and were each handcrafted by community members and partners. So when we say thousands of people have participated in this park project, we are not kidding. 7,200 tiles alone represent thousands of people. Not only that, but thousands of people that we connected with face-to-face, had surveys, attended pop-up events, and attended the grand reopening of the park in 2022. Since then, and I do have my handy-dandy cell phone. Since then, we have seen thousands of people come through the park. Last year alone, there were 7,000 folks that came to the park for special events, and then another 12,000 for programming. So we're really proud of the work that was done in a once vacant 13.5 acre plot of land that drew a lot of negative attention. Today, it draws positive attention. And so this is what can happen when public health and community come together. We may not be speaking the same languages as our medical providers do, but we do want the same things. And so I am very proud to have been a part of public health at this time to create a beautiful place for people to feel safe, to be seen, to be heard, to feel a part of, and to embrace health at their own pace. So I would invite you, if you've not been to Panorama Park, and you would love a tour, I would love to tour you, because every single amenity in that park was desired by the community, from the skateboard area to the climbing boulder to the pump track, to the walking paths, to the mini incline that we have. That was interesting, the mini incline, because to save money on dirt removal, the design team was very creative and pushed the dirt to create Mount Panorama, as it's known by the community, which it's a very small example of the incline, but it is challenging for some folks to climb. So anyways, if you'd like a tour, please let me know. I'd be happy to take you. It's a beautiful place. Summertime is full of people and kids and families celebrating. And of course, we have program partners that have events there that have brought out thousands of people. And yeah, so one of my favorite things. Let me back up a little bit. As many of you know, Councilman Donaldson, I know that you know about the public-private partnership dollars that went into that. The project started as a $380,000 project, and at the time of the grand reopening, it was $8.5 million because of the community engagement. And so I am thrilled to say that public health was a part of that. So I will continue. So we are now in, like I said, completed our first year as a nonprofit. We reached out to community again and said, okay, what are your priorities? And so we met with our board, we met with the coalition partners, which we still convene, we met with community members, and they are saying the same thing. They are saying that community connections are really important to them. We have monthly meetings for community members, highlighting their priorities, what they want to talk about, and then coalition convenings quarterly. We also recently started having town hall meetings with elected officials quarterly, which have been well attended. Health and wellness continues to be a priority as well. And so you'll see our Youth Advisory Council at the top. left-hand side, you'll see some of us on our urban walks on the bottom left side, and Mayor Southers, he joined us on a Southeast Community Cruise. And then also at the Valley High WIC office, we held meetings around gardening and healthy cooking. And so those are some of the things that we will continue to do going forward. There are 12 neighborhoods in Southeast Colorado Springs. Before we went wide, 80910, 80916, now we're going deep because each community is different and faces different challenges. We're also now focusing on thriving economy because we know that to be able to buy healthy foods, we need to have those healthy food options in the community that are accessible for people that may not have cars or may not have a bus or a bus stop close to their house. So those are just some of the things that we're focused on with our 5-year action plan, which each one of you have. And I just share, my last slide is just sharing some funders for Panorama Park, just some of them, not all of them. There are many different funders that came to the table that saw this as a worthwhile investment. And so I'm happy to share more if you'd like. And then also, if you come on a tour with me to Panorama Park, we have donor pavers right at the entryway of Panorama Park. And because of public health's investment in community, public health is also recognized as a donor in the park. There are, in the second column, I've currently listed the funding that we started with when we left public health. We had funding from the Inasmuch Foundation, the Colorado Health Foundation, Trust for Public Land, Lida Hill Philanthropies, and some donors that did not want to be recognized. And then we continue to receive funding from El Pomar. We have a partnership with Generation Wild, which focuses on the outdoors, the Windy Pines Foundation, and again, private donors. On the right-hand side is a list of our partners. When we were at Public Health, partners meant anybody that provided programming for the community. And that we've reevaluated that to look at partners that have been consistent in the community. And so as mentioned during the conversation, during your budget talks, there are some grants that go away, meaning the programming goes away. And so we've restarted that because not everybody continues to be a partner. However, public health has said that they would continue to be a partner in providing data and opportunities for us to connect with any initiatives that would serve the Southeast Colorado Springs community. And through that, I've been connected with UCCS, the Business Innovations team, which is helping us with our economy efforts. So I want to say thank you to everyone. Deanne, thank you. I love you. You're amazing. And to the team that I've been so fortunate to work with, and to you all, Board of Health, for championing community wellness. Thank you.
Well, thank you, Joyce, for that presentation. Let me see if there are questions from board members. I'm looking to my left, and I'm looking to my right. Dr. Vu.
Thank you, Joyce. Southeast is a special place in Colorado Springs for me. Thank you.
I know.
Thank you. I'm slightly confused. I'm a lot confused. I apologize. I couldn't about the funding model. Initially you had mentioned funding came really from El Paso, El Pomar, $300,000 or so over 7 years. Mm-hmm. And then also Colorado Health Foundation?
Yes.
And how much is that from Colorado Health Foundation?
So that was $150,000 from the Colorado Health Foundation.
One time?
One time, yes.
Thank you. And then these other funding partners, or are they part of this?
Yeah, they were, but as you know, funding grant cycles, they have an end date.
Okay.
So we are
okay.
currently seeking, so if you know anybody that is a potential funder, that would be great, because
Okay.
we're currently fundraising right now for 2026.
Okay, thank you, Joyce. So you must have a team that work with you also?
I do, I
Okay,
do.
perfect.
So we are a team of 3.
Okay, perfect. And then can you just very, very briefly describe what's, for the funding, what's being practically done? I don't have a clear concept, I apologize.
So there is no concept as of yet. We
Okay.
continue to meet people, right? It's networking, it's who you know, right?
Okay.
So, yeah, we are in the middle of our funding strategy. We came into the organization with $250,000, and people have seen and recognized our work and wanted to partner with us. So we raised an additional $250,000. We ended the year with a total of $500,000, approximately. I think it was a little bit over. So yes, we are now really, the people that wanted to come and invest in us, they did. Now we're reaching out to more, we're casting a wider net on that.
Okay, thank you. And lastly, you mentioned 2 top priorities that you have heard from the community of Southeast. One is access to health care, which I completely understand. But the other is access to food, or access to healthy food.
Yes. So I will just say, in 2015, there was a community leader that surveyed over 2,000 people. Access to healthy food was a high priority then. It's a high priority now. And so while food pantries are great, it's not sustainable. So we need to have, we do have a large population that is at or below the poverty level. However, we have, the rest of the community can afford to buy groceries. We just don't have those healthy options available. We have, I will just say, we have 3.5 grocery stores to serve over 70,000 people. So in 80916, there's 1 grocery store, Safeway, to serve, I believe it's 40,000 people.
Okay.
In 80910, we have the King Supers on Hancock and Academy. We have the neighborhood Walmart, and we have Save a Lot.
Yeah, thank you, thank you. So that's the part I don't truly understand, because I have patients sitting in front of me every day, and we talk about this all the time. And in my mind, do you mean access to healthy food, or do you mean understanding of choices of healthy food? Because in my mind, everybody I've talked to, they have the same access to unhealthy food as they have the same access to healthy food, and it comes down to understanding of the choices. You travel 5 miles to get food, you can travel 5 miles to get healthy food, you can travel 5 miles to get unhealthy food.
Right, so it's both, right? It's both awareness and education. And it is physical access. So where you're located, where your clinic is located, is on South Academy, across the street from the neighborhood Walmart.
Right, right.
South of that is a cluster of fast food restaurants, right, that serve the Pikes Peak Park area, right? And so if a person is walking, transportation is also a huge priority. If you're walking, it's closer to go to a fast food restaurant or a convenience store than it is to walk to a grocery store.
I guess this is where education comes in, and message from public health is important to me. I know that we can have unhealthy food at a fast food restaurant. I also know that we can have the same access to healthy food at a fast food restaurant, right? So I want to make sure the message from public health is clear, Is it the access or is it choice? If you have low access to food, then the problem should be malnutrition, not obesity, which is a problem in our community, right?
And as you know, obesity rates are high in the community.
Right.
I would love to have a conversation with you to dig a little bit deeper into that.
Sure, thank you.
But I appreciate you for bringing your clinic to the community.
Thank
and
you.
I've met your beautiful wife, and
Thank you.
Yes, just tell her I said hello.
Thank you, thank you. It's important to me because I have this same conversation day after day, patient after patient. Right? So access to food versus choices of healthy food.
Right, and so it is both. So if we could have a conversation later, I think we can dig a little bit deeper into that.
Thank you.
You know,
Okay.
and very good. And I figured out a way to see the hands on the screen. So I noticed that Dr. Chan has her hand up. So Joyce, I think
Okay.
Dr. Chan has a comment
Hi.
or a question.
Hi, thank you. Thank you, Joyce. I can certainly see the passion that you have for your project, and it's really good to see that and for inspiring a community that's cohesive in its vision and participation. And it's certainly good to see that a project was accomplished that helps to mitigate urban or suburban blight. I'd like to follow on with Dr. Vu's comments, and I think that those of us in public health maybe should get away a little bit from designating foods as being either healthy or unhealthy, because the definition of food is that it has nutritional value. That's what food is. And so all food is healthy, but not all quantities of food are healthy. And I think what Dr. Vu alluded to is that there are choices that are very calorie dense and somewhat has less nutritional value, even though it still does have nutritional value, than some other choices. And so I think that when we talk about food in the community, we really need to emphasize choices that are less calorie dense and have more nutritional value. That's just my comment on food. I think that the messaging may have been a little bit, over the years, that our public health message has been a little bit confusing, almost as if calorie dense foods are treats and less calorie dense, more nutritive foods are something that you do, whether, for your health, even though you don't want to. But I kind of veered away a little bit from my initial question. And my understanding is that this program has been in place for about 7 years now. Is that correct?
Yes, it was an initiative under public health for 7.5 years. It is now, we're now a nonprofit, a standalone organization.
Okay. And so 7 years of programming, I would think, is enough time to see some results. And so I'm interested in knowing, number one, what is your definition of success, and what specific health metrics are you using to define improved health outcomes due to programming?
So we're working with partners right now to start an assessment on that, and then also look at measuring success over time. So right now, we measure success by the community that is engaging with health and wellness by choice. So we're seeing more people active at the park, more recreation, playing basketball, more movement, more folks walking on trails, they're biking. So this is an urban area, and we are largely concrete and asphalt. And so helping people understand what is available in the community for them to engage in their own physical health.
Okay, I think those are all excellent measurements. I think we've talked about this before, not with you, but as a board. We're seeing a lot of programs where there's measurements of outputs. And I'm wondering, within your M&E plan, do you have any measurements of health outcomes? Because I think that's what we're primarily trying to impact and primarily interested in, for example, decreasing rates of obesity, decreasing rates of diabetes, decreasing rates of suicides or suicide attempts, decreasing rates of hypertension, and so forth. Is that part of your M&E plan?
Yes, in the future. However, we are not a clinic and we do not collect people's health data. We rely on our partners for that. So we are partners with Peak Vista, and we'll be reaching out to them during our assessment as a key partner in measuring these outcomes.
Okay, and so are you saying that Peak Vista has the data regarding these metrics of health?
So as a part of the Healthy Community Collaborative, partners come together and they share data. And so I think that can be collected through the partnerships with HCC, which is housed under public health. Yes. I said, we do not collect that data as we are not a clinic. We're a community building organization, but I think there's ways to collect that.
Okay, so is there somebody that we would be able to go to look at the data from, say, 2016 prior to this program being implemented versus, say, 2024, about 7 years into this program?
Possibly. I'll have to look into that, and I would love to have a conversation with you directly to find out more about what you're interested in collecting, so that I can go to them and say, hey, do you have this data that you can share? Mm-hmm. I'll just let you know.
Director Ryberg indicated that the primary causes of death within El Paso County is cardiovascular disease and cancer. And so I think that what I would be most interested in are actual health metrics.
Of course. And Deanne is amazing, so I'm sure she'll have that for you.
And one thing I will say, when we made the decision to host this initiative and take advantage of the possibility to address some of the poor health outcomes in a portion of the county, we did look at life expectancy differences impacting the zip codes that Joyce mentioned, as well as other metrics of disease burden. So yes, that opportunity to compare does exist. I will say, since the initiative has now moved outside of public health, as Joyce had referenced earlier, we do stay connected on issues related to data and continuing collaboration. So I think there are opportunities for that in the future. But as we talk about chronic disease prevention as well, access to nutritious food, as well as access to the opportunity to exercise, two strategies to address chronic disease, and really wanted to highlight this activity because it reflects public health partnership with community to be able to address some of those items with the intent to eventually impact chronic disease. The ability to demonstrate that in outcomes may still be something that lies in the future, but when we talk about conditions that influence health, the reason we want to bring this effort forward is because I think that reflects that public health partnership and opportunities to address conditions that influence chronic disease.
Thank you for that,
Thank
Deanne.
you.
Thank you, Dr. Chan. I think Commissioner Geithner has a question. We might make that the last question just so we can sort of stay on schedule for our end time of 10:30. And go ahead, Commissioner Geithner.
Thank you. So I really appreciate, again, the conversation around this entire thing. And I think a little bit of what we're grappling with is now a separate program. So, you know, you're certainly not under the purview of this board to answer for those outcomes. But I have both been a fundraiser for nonprofits and continue to serve with nonprofits. So I do still think that there's a lot of value in this for the organization to really come up with what those outcomes are. I think that all of us as potential donors to your organization, right? Those are really valuable conversations. So I appreciate kind of pulling on those threads, and I hope that public health will still stay engaged. I think that the messaging on this is very important. We know that those things, nutrition, exercise, we know that they're great. And they're important for chronic health, but I think if public health can measure and equate some of these partnerships and the things that public health has done to start these partnerships and truly show through the data those outcomes, I do think that is significant when we talk about where do we spend our money, how do we make a case to taxpayers that this is a good investment, and I think that is a good ongoing continuing conversation. So just wanted to make that comment, but now to my question. I do appreciate that there is a emphasis around a thriving economy, because I do think that is a very easily overlooked part of what health is a part of, is that when you belong to a thriving economy, you have those resources to make different decisions that are also very important. Lots of great conversation that has happened around that. I'm curious on page 8, where it talks about a thriving economy. It says over the next 5 years, Rise Southeast will support dedicated partners and there lists a couple of things. One of those is pursuing legislation to create accountability for property owners in supporting their leasing businesses. Can you just tell me what that legislation would look like? I'm just curious.
So, from a community standpoint, I don't know if you've toured Southeast, but it really looks deserted when it comes to businesses. And not only vacant storefronts, but also a lack of taking care of properties, right? So it looks trashy. Sometimes on a windy day, there's trash all over. People don't take care of their weeds. We always, not all, I don't want to say always, but we've put the onus on residents taking care of their yards. We'd like to see property owners taking care of their property and making it, and beautifying it, making it a place where people want to have their business, where people want to go to a business, where they're proud of the community. We want those property owners to be proud to be in Southeast. And Councilman Donaldson, you know, there's a lot of property owners that live outside of our state. And so that's one of the things that we're talking about. And then also to your point about nutritious food and SNAP, limiting what people can buy, that's great. But if the convenience stores or the grocery stores don't, I will just go to the convenience stores. If the convenience stores, if the majority of what they're selling is candy, chips, soda, whatever, and they have a limited amount of nutritional food, then that limits access to food in general.
Sure, and I think that's actually why that policy is very important, because if people can't spend the money on that, businesses will respond to the demand. And so I think it's just interesting because we're getting a lot into policy, which I think is actually very important. But I want to go back to my question a little bit, because I'm hearing your intent. I'm hearing you saying this is what we want to be the result of the policy. But if you're advocating for a specific policy, you've got several policymakers in the room. You have people who can influence policy. So what does that policy look like in your mind? What kind of policy are you hoping policymakers enact that you think will get to that intent?
it's taking note of people that have historically had less voice in politics. And we won't get into politics right now, but I will just say we really rely on our elected officials to speak not only for the whole of El Paso County or the whole of Colorado Springs, but also look at communities that have been, and I hesitate to say this because I don't want to place blame, but overlooked and underserved.
I understand, but I'm asking about a specific policy to solve the problem.
We do
So you
not
don't
have
a specific policy you're advocating for at this
Not
point?
yet.
Okay.
We are a new nonprofit.
Okay, nope, I understand. I just wanted to understand if there was a specific policy that certainly we could potentially have people in this room that might be able to help with if it was something that we could get on board with, but I think maybe a later conversation about that would be good.
Please.
Thank you.
Thank you.
And thank you, Commissioner Geithner. Thank you, Joyce, for being here today. And you see there's a lot of inquiring minds here on the Board of Health. Lots of questions. Thank you very much for highlighting RISE for us today.
Thank you.
And with that, I think we'll go to the Tobacco Education and Prevention Partnership.
Yes, so next we have our Tobacco Education and Prevention Partnership led by Jennifer Lang, and we wanted to provide an update on this. Our first presentation highlights some of the community partnerships we've been engaged in, and although that is a theme within TEP as well, this programming is ongoing within the agency and led directly by our staff.
Hi, good morning. My name is Jennifer Lang. I am the Division Director for the Tobacco Education and Prevention Partnership, as well as Fountain Valley Communities That Care programs. I'm here today to discuss the impacts of tobacco and nicotine use in the state of Colorado and highlight some of the work that we're doing here locally that specifically addresses chronic disease prevention. I am mindful of our time, so I will try to run through this and hit the highlights. If you do have any questions, of course, feel free to ask. Oops. Okay, here we go. So tobacco prevention plays a very integral role in preventing chronic disease. As you can see, cigarettes or smoking is the single most preventable cause of death in the United States. It harms nearly every single organ in your body, and it is attributed to 1 in 5 deaths in our country. In fact, smoking kills more people annually in our country than AIDS, alcohol, car accidents, illegal drugs, murders, and suicides combined. Secondhand smoke exposure is also harmful for both adults and children, and can lead to numerous chronic health conditions. As we know, it can even lead to death. Sorry, I don't know why this isn't working right. Okay, so before we look at specific interventions from the TEP program, let's look at some usage data and trends. This slide shows adult cigarette smoking rates continue to be on the decline. Statewide, it's about an average of 11%. We are slightly higher than that here in our county. As you can see on the right side of that slide, adult vape use continues to increase over the past few years. And again, those rates are slightly higher here in El Paso County than they are on a statewide basis. Some really good news that we love to highlight is that nearly 3/4 of adult nicotine users have attempted to quit within the past year. Here we go. And now, excuse me, next we're going to look at youth nicotine use. So from 2021 to 2023, the rates of high school students in Colorado who have ever used a tobacco product has remained steady, fairly steady around vapor use. That during that same time period, the rate of cigarette use has declined by about 4 percentage points. There we go. Okay. This next slide looks at the differences between vape use among middle schoolers and high schoolers in Colorado. The really good news is that high school students in Colorado are vaping at slower rates than the national average. However, middle schoolers in Colorado are vaping at rates slightly higher than the national average. So as you can see from these numbers on this slide, tobacco use is very costly for all of us. Thousands of lives are lost each year, and about 16 million people in the United States are living with a chronic illness caused by tobacco use. This results in increased healthcare and Medicaid costs, as well as billions of dollars lost in productivity. Colorado residents pay about $772 in additional state and federal taxes due to the toll of tobacco use. So here in El Paso County, the Tobacco Education and Prevention Partnership focus on three areas. We first look at prevention. We partner with youth with the ultimate goal of stopping use before it ever begins, and helping youth make those educated decisions. We also partner with various community organizations and businesses to help equip them with the materials and resources needed so that they're able to then provide programs and implement programs within their communities that meet the needs of their clients and populations. And then lastly, we focus on cessation. So we connect current smokers and nicotine users with free, low-barrier resources to help people make the best choice for them around the decision to quit. So again, one of our main roles is to help prevent use before it begins. And this comes down to two major factors. We know that most smokers and nicotine users begin before the minimum legal sales age of 21 years. And again, the two main driving factors of this is the developing brain of youth. We know that the prefrontal cortex area of the brain does not stop developing until age 25. This is the region of the brain that controls attention, learning, mood, and decision making. So again, once we can get youth a little higher on the maturity scale, the less likely they are to make the choice to use a deadly product. Let's see, and then we'll also look at, teens are more susceptible to addiction as well. We know that the earlier age that people begin using these products, the more likely they are to become lifelong users. Another reason we focus on youth prevention is the predatory advertising and marketing practices of the tobacco industry. They use such things as fruity and sweet flavors, trendy packaging, as well as retail and social media advertising to attract new users. And the tobacco industry spends approximately $23.5 million each day advertising its products, which is nearly $1 million per hour. There we go. Sorry about that. So one of our more popular interventions that we use here in El Paso County are SWAT clubs, or Students Working Against Tobacco. TEP offers a competitive mini-grant application process at the beginning of each school year, and it's open to all public, private, and charter middle and high schools in the county. The clubs that we currently fund include school districts that encompass the diverse populations across our county, including Calhoun, Falcon, Manitou Springs, Fountain, Security, and Widefield, as well as Colorado Springs. The main goal of SWAT clubs are to be that voice to promote nicotine-free lifestyles within their communities, more of that peer-to-peer education. Each SWAT club is responsible for completing the Tobacco-Free Schools checklist to ensure proper signage is around their facilities. Each program is to look at alternative to suspension programs to implement within their schools, and then also present information about their club to a stakeholder group such as a school district wellness committee, a school board, or even the Board of Health, which actually happened I believe it was about this time 2 years ago. So we enjoy the opportunity to show off the work of our youth.
Jennifer, could we have just one question
Oh,
right
yes.
now?
Yeah, if you could go back to that slide. The utilize an alternative suspension program such as Second Chance for students in violation of TFS. What is the Second Chance program?
The Second Chance program, so what we encourage is for school districts to build upon that education around prevention, so a student that maybe they're found in possession of a vape product or even Zen, rather than going straight towards suspension or expulsion, take time and educate that student around the harms of tobacco and nicotine use. There's data that supports the education piece is a key component in then helping students then decide to quit. So again, it's up to each school. Each school, of course, has the autonomy to make the decisions best for them, but that's the program that we tend to promote.
So I'm very interested in this because I've not heard of it, and I am the board president of a charter school, and so this is something that I think I'd love to learn more about. So maybe you have some additional information, but that's something that program. Now I don't know that I'm in favor of not suspending a child, but I might be in favor of doing it in conjunction because I do think consequences are important for kids too. But if you could send more information about how those materials are accessed or what that information is, I was not aware of this previously, and I would bet there are a lot of other school leaders in that same position. So I'd love to find out more about it. Thank you.
Absolutely. I'll be glad to get that for you. Let's see. Trying to remember where I was. Okay. So each school has the autonomy to provide that peer-to-peer education as they see fit. District 49 has just recently utilized a new model where they are encouraging high school students that are active within their SWAT program to go to the elementary school students and provide that education. Again, really a good opportunity for the high schoolers to be a good influence on the younger students. And then also here's some additional pictures around some of the activities that have happened this year. The Valentine's Day, Don't Date the Vape, very creative. Thought that was a great idea. And there on the right, there are students that are signing an anti-vape pledge. There on the bottom left, some clubs order swag, so they're modeling their sweatshirts with healthy lungs on the background. And then there, that smaller picture on the right is student demonstrations around showing a healthy lung versus a diseased lung. So let's see. Sorry. I wanted to point out that over the past year or so, TEP has been very fortunate to partner with a nursing doctoral student named Erin Sanborn from the University of Colorado Anschutz Medical Campus to complete a formal evaluation of our SWAT clubs. The final evaluation is still in progress. However, preliminary research findings are showing that SWAT clubs are effective in increasing that risk perception of vaping among participants based on pre and post surveys. Erin's research also points towards the need to target middle schoolers, as this population demonstrated the largest increase in risk perception. More research will be, of course, available later this spring as Erin wraps up his project with us. So the second main area that we focus on is to provide trainings, resources, and materials to a variety of community partners. There along the right side, you can see some of the examples of people that we tend to partner with most. Again, we rely heavily on our partners to implement interventions within their populations that specifically focus on their clients and their needs. And here's a couple pictures of our staff out in the community providing trainings to both community groups as well as medical providers. We're also very active at community resource fairs as well as community events. So education, I'm sorry, where should I be? There we go. Okay, sorry. One main focus, let's see. So education around tobacco and nicotine trends is a key focus for us. We found that many parents and caregivers honestly don't know what current vape products look like. This education allows for the increased knowledge and awareness about what they can look for if they suspect that a youth in their life may be using tobacco and nicotine trends, and how to have that conversation with them. And lastly, TEP connects smokers and nicotine users with free low-barrier resources to help them quit. We primarily direct people to the Colorado Quit Line, Baby and Me Tobacco Free, and My Life, My Quit, based upon those individual needs and the type of support that is needed. So TEP has been a proud part of El Paso County Public Health for about 25 years now. We are grant funded through the Colorado Department of Public Health and Environment. These voter-approved measures have allowed for long-term funding sustainability and allowed us for the ability to build those really strong community partnerships. TEP is just one of many grantees throughout the state working on very similar initiatives. The team, as shown here in this picture, we're just one piece of the larger puzzle in helping address tobacco prevention to reduce the prevalence of chronic disease. And that is, oops.
And that's it. So I want to say thank you, Jennifer. We only have about 10 minutes left before 10:30, so we may not have many questions. I bet we do, but we'll just wind up not asking them. Only thing I want to point out is you mentioned how the brain development doesn't really end until 25, and my wife is hoping mine gets there at 65, so just a little slower. I just had to say that. I've been trying to remember that the whole time. Is there anyone that has one? This was very informative. I really appreciate it. Lots of good information in the slides, and I think the effort here was to focus on the two leading causes of death in El Paso County: cancer, cardiovascular. This is a program inside of public health addressing tobacco-related cancer, which is 25% of it. And then the previous program, RISE, was a program which to some degree tries to address some of the cardiovascular side with exercise, diet, and that is something that may have started in public health, but now is out on its own as a 501c3. So now I've taken 2 minutes talking. Does anyone have a question, one question for Jennifer before we move on? Yes. Commissioner Guyton.
And I'll be super quick. I really appreciate some of the data specifically around the effects in Colorado and also across the United States. The youth data was obviously much more localized. I'd love to see more of that data if that's available, more localized to El Paso County specifically. So I don't know if that's available, but if that's something, statistics around how much it's costing us locally, just any of those things that are more localized to us would be very valuable if you have that information to send it.
We'll work on that. We have not had local youth data available to us for El Paso County since 2019. However, from what I understand, there is some information that we hopefully will be able to share. It's not quite as statistically valid as the Healthy Kids Colorado survey, but there is some data out there that helps support some of these statewide trends that we're seeing here locally.
Thank you. Always comes up, as Dee and I have had this conversation around healthy kids too, a topic for another day.
Okay. Thank you very much, Jennifer.
Thank you all.
Good job. And with that, I'll hand it back over to Deanne. We only have one item left, and it was an update on measles.
Yes, we wanted to provide some timely information regarding measles, as many of us are seeing media stories about ongoing outbreak in Texas. And we have our co-medical director, Dr. Paul Mayer, as well as Haley Zachary, our division manager for communicable disease.
Okay. Dr. Mayer, you want to kick us off, please?
You bet. So I'm Paul Mayer, co-medical director, El Paso County Public Health. And we thought it would be helpful to just give a brief clinical overview of measles. So measles, as you probably have heard, is one of the most contagious diseases of humans. And after exposure, the incubation is roughly around usually 2 weeks. It can be as long as 3 weeks or 21 days. It starts with a prodrome fever, typically a high fever. 104 is not uncommon. And with that, then pretty rapidly develop cough, runny nose, red eyes, or conjunctivitis. So the prodrome lasts somewhere around 2 to 4 days typically, and then the patient will develop a rash. The rash of measles is, it's described as maculopapular. In medicine, that means both flat and raised areas of a red rash. Classically begins in the face and spreads downwards. But it's the complications of measles that makes it of such public health interest. As you've probably heard, we've already had 2 deaths attributed to this current outbreak. Roughly, statistically, about 30% of patients who develop measles will develop some complication of their measles. The more common complications are things like diarrhea or ear infections. Pneumonia is the one we fear a lot because the pneumonia associated with measles is the #1 cause of death from measles. About 6% of patients overall will develop a pneumonia related to their measles. That can be either from a secondary bacterial infection or from just the primary infection of the lung from the virus. Other worrisome complications are encephalitis, which can lead to permanent long-term disability, and another associated syndrome, ADEM, which is another neurologic condition that can also lead to permanent disability. In a resource-rich country like the United States, the death rate from measles overall is around 1 to 3 per 1,000, though that can go up considerably in other countries. And again, just an idea to give you a very brief clinical overview, and I'll turn it over to Haley Zachary, who will talk about our current measles situation in the United States.
Thanks, Dr. Mayer. So as Dr. Mayer mentioned, measles is highly infectious and it can be very severe, which is why we poise ourselves in public health to be able to respond to it. So currently within the United States, there's multiple different jurisdictions reporting measles cases and measles outbreaks. As of last Friday, there were over 18 jurisdictions that were reporting cases of measles within the United States and multiple jurisdictions bordering Colorado. So we're seeing outbreaks in New Mexico, Texas, Oklahoma, and Kansas as well. And right now, there's probably over 400 cases of measles that have been reported thus far in 2025, which is already more than the number reported in all of 2024. So certainly monitoring the number of cases as they are increasing. Over 75% of these cases that are currently being reported are in those 19 years and younger. 17% of cases have been reported as being hospitalized with complications from infection. And as Dr. Mayer mentioned, there's already been 2 deaths being reported, 1 in an adult and 1 in a child. However, even with the number of measles continuing to increase, it is still considered a rare disease within the United States. And because of that, there's needed to be a lot of education to our partners in our community about what the concerns are surrounding measles, because a lot of folks haven't seen it, haven't heard of it in quite some time. Just to add some context to that, in the last 10 years, El Paso County Public Health has only responded to 2 cases of measles who have spent time in our jurisdiction, but were not our residents. So we've monitored their contacts and done follow-up investigations, but they were not actually our cases. So in my time here and in the last 10 years at least, we have not had a case of measles here in El Paso County. There have been reported cases of measles in Colorado. The last one was in 2023. So what are we doing in El Paso County to make sure that we're prepared to respond? So as I mentioned, a lot of providers have not actually seen a case of measles within the United States in quite some time. And so there's a lot of education being provided to our medical community so that they're armed with the appropriate information and tools to correctly identify a case of measles, also know how to prevent the disease in folks, and also know the appropriate ways to test for it so that we're able to ensure that people have the right information at the right points in time. We do this primarily through health alert networks. So it's essentially an email, I'm sure Dr. Vu gets them, to all of our medical providers so that they are all getting the same information. And then we locally bolster that with a lot of local newsletters, as well as communications to providers and organizations as well. So we here in public health also serve as the subject matter experts. We work very closely with medical providers and the community to ensure that they can get answers to the questions that they have when they need them. So when providers have a patient in front of them that they're concerned about, they can reach us 24/7, and we can have that direct conversation with them to ensure that they have the appropriate information to treat that person who's in front of them. We also answer a lot of questions from the community and partner with organizations to make sure that they're also prepared. And then lastly, we would do a lot of internal planning with our community partners within El Paso County to ensure that we are well poised to respond to a case and contact investigation. We work very closely with our immunizations partners, our emergency preparedness partners, and our leadership to ensure that we are ready. Should we have a case, these tend to grow very large, very quick, and we want to be able to rapidly ramp up that response and respond appropriately. And with that, I would take any questions or concerns.
Okay, and we do have a question from the Vice President, Doris Ralston.
So thank you for the excellent information. Wanted to know about vaccination rates in our county. Do you have any idea what those are like? And then the second question that I have is, what are the plans to be proactive to help prevent, to encourage, especially children, to get these MMR vaccinations?
Yeah, I am not our immunizations program manager. I did speak with them this morning. Our immunization rates for our MMR in kindergartners has declined. So for the 23-24 year, we were at 79.2% of kindergartners were up to date on their immunizations. We should have the rate for this year in the next few weeks, is my understanding. I'm not sure I can speak to proactively what our immunization clinic is doing for that piece of it. I'm not sure if Dr. Mayer or Deanne are able to speak to that piece.
Yeah, I can comment on that too if you want, Haley. And I don't know if Christy Durbin's there in the audience because she would know this very well also. So for a while now, actually, our immunization team has been pretty aggressive about trying to address our MMR rates. So we have data from the state that will give us pretty detailed analysis of school by school, which schools in the state have better or worse rates, and we can try to work with the school nurses to try to do on-campus events if they'll allow us to get into the schools. We also know the line list of people we vaccinated in our clinic who haven't come in for the second vaccine or who are due for their vaccines, and so we'll reach out to them and do a lot of outreach to people with phone calls and other things to try to get them into the clinic to vaccinate them.
Thank you.
Okay, any other questions for Haley? And
Mr. President, there are a couple questions online.
Oh, okay.
And I have my hand up.
Okay, now I see it. Go ahead, Hunter.
Thank you, Mr. President. So that was kind of my question. I did want to further probe on that though. So do you see, so this is really interesting data. So basically this is for people who are not getting vaccinated, and the majority of those are children. Is that what's happening?
Sorry, Hunter. Do you mean when you say this, you mean this outbreak?
Sorry, yes.
Yes, this outbreak is overwhelmingly being driven by unvaccinated people. There are, in any measles outbreak, you'll see a few folks who are vaccinated, even a few who are fully vaccinated, but that's much more rare. And if you look at those cases, they tend to be much more mild too. So yeah, this is driven overwhelmingly by low vaccination rates, in particular in certain communities. Yes, that's correct.
And I'm curious, and I don't think this would be difficult to find, but it's my understanding that in Colorado, to attend a K through 12 school, it's mandated that you are vaccinated against measles, unless you have a waiver. So are we seeing a correlation in those waivers commensurate with the increase in this measles outbreak?
Well, I think overall we've seen an increase in people waiving out of the vaccine requirements for school, and that's a problem we're trying to address for sure. Yes. So yes, that's correct. We are seeing more people waive out of their vaccine requirements.
Okay.
Okay.
I think that's it for now. Thank you.
All right. Thank you. Thank you, Doctor, and thank you, Haley. Okay. The only item we had left, but go ahead. Yes, sir.
Oh, sorry. I just want to mention, I think Dr. Chan has her hand up as well.
Oh, okay. My apologies.
Do we know what percentage of the measles cases that have been reported nationwide are for under 1, and what percentage are vaccine age eligible who are unvaccinated?
Not have those numbers in front of me. I can look and see if I can find them though.
Have you seen an uptick in vaccine uptake after the childhood deaths were reported?
So I would not have access to that information because these are other jurisdictions outside of Colorado that are reporting these outbreaks. I'm not sure if there have been any reports on national calls about vaccine uptake.
Oh, I mean in our county, because I know that there's been reports of increased uptake after the childhood deaths were reported in other areas, but I'm talking about in El Paso County, if the vaccination rate for vaccine eligible individuals is 75%, that is insanely low. Insanely low. It needs to be 95%.
Yes, and again, our immunizations program manager is not here. She would be the best person to speak on that. I'm sure we can follow up though.
Okay, thank you.
I can mention, Dr. Chen, I don't have hard numbers for you, but I can tell you that anecdotally, we've seen a great increase in interest in MMR vaccination, which is encouraging. And yeah, we can get you some of those numbers.
Thank you.
Okay, thank you, Dr. Chen, Dr. Mayer. And it is past 10:30, but we'll take another question or two, and then we'll get Taylor to answer the question we started off with. Go ahead.
Thank you. I understand the timing, but I do think these are important topics we need to discuss. I just think it's important in this discussion, I want to express that I think it's really important that we respect people's choices when it comes to vaccinations and their personal health with their families. This is a huge conversation. Obviously, we have a lot of lack of trust. And as a result of the COVID pandemic, I've been very vocal on that. I think it's very clear that we have a lot of concern about how the government talks to people and how we have classified people, especially since the COVID pandemic. So I just think it's important, and I just wanted to state, I think it's very important for us to respect people's choices. And if we want to educate and offer and give them opportunity, I think that is great, but we need to be careful about how we are phrasing things when we talk about people's personal medical decisions. Thank you.
Okay.
Let me just jump right in here. I actually would echo Commissioner Geithner's position and concerns. I think it's 100% up to the patient or the parent whether they want to take the vaccine or not and make that choice. I think that it's important that they know the risks, and I think that with personal choice also comes personal responsibility, and that outbreaks are not limited just to people who are vaccine eligible who don't take the vaccine. I think the primary concern is transmission of measles to those individuals who are so young that they're not vaccinated yet. So what I would say is that make your choice. If you get measles, maybe insurance shouldn't cover it, because what you're saying is you don't feel like it's a risk. Well, it's like not getting insurance.
Okay. Thank you very much, Haley and Dr. Meyer for the information. And now we'll go back to what was the topic we had, Taylor, that we sent you on a research project?
Fund balance.
Fund balance.
So,
That's what it was.
I appreciate all the questions and the vested interest in the budget moving forward. So estimated at the beginning of 2025, with everything that was presented today, the estimated number of fund balance is about 7.48 million. That equates to 27% of 2025's budgeted revenue, which is how the fund balance is calculated. So you have to calculate on the budgeted revenue that's brought in.
Okay, so 7.5 million, 27%.
Yes, that's at the start of
Start of the year.
2025.
If you didn't do this math, don't worry about it, but if we draw down by almost $1 million, what percentage would that be?
So that put us at about 6.5 million, 6.51 million. That's drawing down 970,000. Assuming that our revenue was exactly the same, that would be around 23.8%.
Okay.
Because again, it's based off the revenue number. So if that revenue number decreases, that will change. So if we draw down what we're budgeted to at 970,000 and some change, we'd be at 6.5 million. And with our current budgeted revenue in 2025, that would put us at about 23.8%. And just to reiterate, the policy is a minimum fund balance policy of 18 to 21%.
Okay, I've got all that. I'm going to look to my right at the monitor screen so I don't miss a raised hand again, and I don't see any. It is now 10:37, and do we have any board member questions on that topic? We've got the information, as I know Taylor likes to say, promises made, promises kept. He got that information for us. There's no laughter, so my joke fell flat. Are there any questions for Taylor? If not, and I don't see any, and I'm looking all over, then here's a chance for alibis. If there are none of those, then we will say the meeting is adjourned.
Thank you all.
Motion to adjourn.
Thank you. Not really.
Bye, Deborah. See ya.
Yeah.